Good morning, guys. It's Natalie. I am one of the ICU nurse practitioners. I just wanted to give y'all a little brief overview of the basics of LIDCO. I know we have a lot of new nurses, and I know a lot of times we just see the machine and it's been there for days and no one has been paying attention to it. So I kind of want to tell you what we are paying attention to and what we are actually trying to accomplish by having LIDCO on our patients. So LIDCO is actually the brand name of the machine, but it is a leading provider of advanced hemodynamic solutions. So, not just your normal vital signs. We're talking about cardiac index, cardiac output, those kind of things. It is a beat-to-beat parameter that is displayed. It provides immediate feedback on the patient's hemodynamic status. So LIDCO can monitor all the following parameters: stroke volume, cardiac output, oxygen delivery, stroke volume variation. Those are sort of the big things that we look at. Just as kind of a background too, LIDCO, some of you may have been around, but LIDCO is sort of taking the place, for the most part, of Swan-Ganz catheters. Not everywhere, but Swan-Ganz catheter is essentially a right heart cath, right? It's a pretty invasive procedure that goes and is looking at the going through to the pulmonary artery. So, it is very invasive. The risk of complications, especially, life-ending pulmonary artery ruptures and things like that, are very real. So this has been a nice alternative to get essentially the same information, but have a decrease in the amount of complications that arise. Because, like this will show how LIDCO works, so it uses just an arterial line. So an existing arterial line and blood pressure transducers to monitor hemodynamic parameters. It converts beat-to-beat blood pressure into its constituent parts, flow and resistance, and it is patient-specific for age, height, and weight. LIDCO is based on physics and physiological principles. It focuses on pulse power analysis rather than waveform shape and contour. So while LIDCO does a lot of stuff, I want to focus mainly on just two parameters, particularly cardiac output and stroke volume variation. But I did put cardiac index kind of goes hand in hand with cardiac output. It's a 2-to-1 ratio essentially. But cardiac output, the norm is 4 to 8 liters per minute. And then stroke volume variation is 10 to 15% on patients that are on controlled mechanical ventilation. Our kind of parameter here at MD Anderson is we would ideally like SVV less than 13%. So why monitor cardiac output? Cardiac output is the amount of blood that is ejected from the heart per minute. So monitoring cardiac output in patients is important because it ensures that there's a sufficient volume in the body to transport oxygen, right? So blood carries oxygen. If you don't have enough blood, you're not going to be oxygenating well, you're not going to be perfusing well, all of those things. So it makes sense, right? If your cardiac output is low, you don't have good perfusion. So monitoring cardiac output can help clinicians manage fluids, monitor therapeutic interventions, improve patient outcomes. So looking at that, what you will most likely see in our patient population is when we will try to, before we even kind of get this, we'll have gotten an echo and see what is the patient's overall heart function, what is their EF, how well is the heart pumping. So, you have these people that are 25 to 40%, we know their heart is inadequately pumping, and then we hook up this LIDCO, we see a low cardiac output. That lets us know, hey, this person they need some inotropic help, right? They need some milrinone, they need some dobutamine, they have some legit heart failure. And then if they have low blood pressure because they are inadequately perfusing, they're essentially going into cardiogenic shock. So this is a very good indicator for that for us, that they're going to need inotropes. Yes, we can manage them with some fluids. It's not going to hurt them. They need a little bit, especially if they are profoundly hypotensive, they're going to need some fluids. But inotropes are going to be our way to go, especially if they have a low EF. So that's why having the echo is really nice. If they have a normal EF, but they're hypotensive, we know, hey, we can give these people some fluid and let's see what they do. And there's also been, and I will show you at the end, but lots of positive outcomes in being able to monitor and help improve patients' cardiac output. So cardiac output continued. Fluid administration, it's one of the most common interventions to help increase cardiac output. And you do not have to slam these people. Like I said, even if you don't know what their EF is, be on the prudent side, 250 to 500, and watch and see what happens to their cardiac output, okay? Like I said, it's a beat to beat, so it will be changing nonstop because it's being read off the art line. Fluid administration should be balanced to avoid hypovolemia and hypervolemia. So we know this, right? Hypovolemia can lead to shock because if the patient is underperfused or essentially dry, they're going to be underperfused, right? You're going to have low blood pressures. They're going to start getting AKIs, all of those things, which can then eventually lead to shock. So euvolemic is our goal. These patients that also have low EFs, if we flood them, we are going to push them over. They are not going to be able to tolerate all of that fluid. Their lungs are going to get overloaded. Their heart is not going to be able to handle it. That's why those are the patients that need just a small amount of fluid resuscitation, and then they would benefit from an inotrope, like milrinone, like dobutamine, that helps with squeezing their heart and getting that blood pumping. Stroke volume variation. Stroke volume variation, it's a reliable predictor of fluid responsiveness. So that is what we are looking for. So you have these people that come in with SVVs greater than 25. It's a pretty good indication, like maybe they would benefit from some fluid. So we would give them, same thing, you don't have to go big. You can go 250 or 500. If the SVV starts dropping, you can see that they are responding to our medical management, right? Give them a little bit more. So ideally, SVV less than 13, as long as it's less than 13, they don't need fluid. They may need something else, but the fluid is not the answer, okay? There are some limitations to this. Stroke volume variation has been proven effective in patients that are on mechanical ventilation. They have a steady respiratory rate. It's not variable. So if they are not vented, it is a little more inaccurate, as well as PEEP. Increasing PEEP greater than 10 increases SVV. Arrhythmias, this is being read off of an arterial line. So you have a patient that's in AFib that does not have a regular rate and rhythm, you're going to have significantly more variation than you would on someone that was in sinus rhythm. Vasoactive agents as well. These can make patients more tachycardic. They can make patients more bradycardic, depending on what medication they are on. So all of those things are going to cause an increase in the variation that you already were going to have. And then general anesthetics, propofol, fentanyl, etomidate, they increase the variation due to circulatory inhibition. So proven clinical outcomes. So there were two, these were done by LIDCO, but there were two pretty significant ones. One was with 600 patients that had emergency lap surgeries. The patients that were hooked up to a LIDCO had a significant decrease in mortality at 30 days and at 180 days. So, we see it that long term it made a difference to accurately be monitoring their hemodynamics from a intravascular standpoint, right? That's what you're looking at. You're not just looking at, they have a low or high blood pressure. This is giving us more information in kind of a real time with a little bit less complications than you would with this one, because you have an arterial line, which is much less invasive. Then there was a big randomized controlled trial of 743 patients who underwent major abdominal surgery. So major abdominal surgeries, these people, they lose lots of fluid. They have, some of them can get very septic. So fluid resuscitation plays a really big role in these people. So they found that the patients that were hooked up to the LIDCO had a 20% reduction in post-op complications. And as a result, the patients that had the LIDCO on average saved $530 than the patients that were not monitored. So the 20% complications is pretty good. And then in summary, monitoring all of the things. So blood pressure, SV, cardiac output, SVV, it provides you a complete hemodynamic picture and ensures that there's sufficient volume and pressure in the circulation to transport oxygen and meet every patient's unique needs. All of our patients are different. We do truly have reasons who gets LIDCOs and who doesn't. Essentially once they are out of that acute shock phase, or they were in, like I said, out of the shock phase, they were in cardiogenic shock, we got them on their inotrope, they're better, their cardiac output is normal, I think that is a good time to then discuss, can we DC the LIDCO? So otherwise, that is a very quick, kind of down and dirty little presentation of LIDCO. We can definitely go into more depth at another time, but if y'all have any questions, feel free to reach out to me. Here's my contact information. Thanks.